Our quality improvement project was the standardization of PACU handoff communication process and structure. The Cleveland Clinic performed over 208,000 surgical cases in 2016. Despite this large volume, the handoff communication process and structure from anesthesia providers to post-anesthesia care unit or PACU nurses had not been standardized. The lack of standardized structure may result in the omission of pertinent medical information regarding the patient and may ultimately lead to patient harm. For example, a patient with baseline altered mental status may return to the recovery room and have unnecessary tests and imaging performed when they are just at their baseline. So our goal was to reduce handoff emissions by 25% between anesthesia providers and PACU nurses in our main PACUs by December 1st, 2017. We expected that the standardization of the patient handoff would lead to a reduction in medical errors and avoidance of adverse events that may be due to miscommunication, and ultimately a reduction in time that the patient needs to spend in the recovery room. We sent out pre-intervention surveys to be utilized by our PACU nurses during a day of handoffs, and out of 140 surveys, there were 100 total omissions, 80% of which involved PACU orders not being placed or pertinent patient past medical history. Other errors in omission included pertinent medications, preoperative cognition, fluid management, pain management plan, airway details, the procedure and the reason for the surgery, and IV access. On October 1st, 2017, we implemented our first intervention, which was placing a checklist created by a collaboration between anesthesia residents and nursing colleagues at each bedside in our PACUs to be used during handoffs between anesthesia providers and nurses. This led to an awareness of the necessary information to be included in handoffs. However, many of our checklists were misplaced or discarded due to lack of awareness of our project in general. 2 weeks later, we modified our implementation of our checklist by laminating our checklists and securing them to the bedside tables. This led to a 17% reduction in total medical omissions and led us to believe that we would continue to communicate and adjust to the environment and improve our process. 2 weeks later, for our third intervention, our administration sent emails to the entire Anesthesia Institute and Nursing Institute acknowledging our progress and providing a reminder to continue to use our checklists. This led to an additional 15% decrease in total omissions. We learned from this that consistency is essential and that we needed to continue to find additional ways to make this process easier on those involved. Here's a picture of our bedside PACU checklist. As you can see, after post-intervention survey 2, we saw a 32% reduction in omission and medical information during sign-outs. As a secondary outcome, we also saw a reduction in PACU handoff times to below our goal of 6.5 minutes. In conclusion, we will continue to revamp our handoff process in order to provide the most sustainability and standardization. We plan to work with our anesthesia record-keeping system, or ARCS, to streamline the handoff approach and include our checklist on the printout that nurses receive before receiving the patient. We also plan to survey PACU nurses monthly in order to monitor our progress and continue to improve. Thank you very much.